Good afternoon. How are you all doing this afternoon? Since January 2009, Dr. Julio Frenk has served as the Dean of the Faculty at the Harvard School of Public Health and the T&G Angelopoulos Professor of Public Health and International Development, a joint appointment at the Harvard Kennedy School of Government and here at HSPH. Born in Mexico City, Dr. Frenk received his medical degree from the Autonomous University of Mexico and went on to obtain 3 additional degrees from the University of Michigan, a master's in public health, a master's in sociology, as well as a joint doctor of philosophy and medical care organization in sociology. During his professional career, Dr. Frenk has held leadership positions at the National Institute of Public Health of Mexico, the Mexican Health Foundation, the World Health Organization, the Bill and Melinda Gates Foundation, and the Carso Health Institute. Dr. Frenk is an eminent authority on global health. As a minister of public health, he pursued an ambitious agenda to reform the nation's health system, which included Seguro Popular, which expanded health care to tens of millions of previously uninsured Mexicans. He is a member of 10 editorial boards of international journals and 12 scientific and professional associations. If you could please join me in welcoming Dr. Frenk.
If I might, Julio, just take 1 minute to introduce the series. So this is the first in the series aimed at students. The Division of Policy Translation and Leadership Development has one simple mission: to link the school with world leaders with an exchange both ways. You're sitting in a facility, and the reason why we're using it, that is both a television studio and has the ability at the highest level to webcast worldwide. All our speakers that will appear here will be on a website. They will be shown other parts of the school. They'll be available to be shipped to press and others. So anything they say is on the record. The purpose of these sessions is to get key decision makers to talk about the basis for the decisions that they're involved in, and to have students actually talk to them about what went into the decisions at the time they were made. People come to Harvard because they want to influence the future of world events. To make that happen, the division wants you to have a chance to really talk to people who have influenced those events. So when it's your turn, you build on what they've done. With that, it's a pleasure for me to turn it over to Julio.
Thank you. Thank you very much, Bob. And well, it's a pleasure to be here launching this this series. I'm in a sense wearing 2 hats. One is as the dean here, where clearly one of the major initiatives we're having is policy translation and leadership development as a big part of our academic mission, so that we can be engaged in producing research, in reproducing research through education, but also in translating it and making sure we generate this sort of dialogue. And then the second hat is as the former Minister of Health of Mexico, which is the main reason I'm here, to share with you some of the process for decision making. And I hope this will be more of a dialogue, and feel free to ask questions and so forth. I mean, basically, let me tell you in a nutshell what happened in Mexico during the period of time I've served in the government, which was from 2000 to 2006, 6 full years. That's we have a presidential system like in the United States. The president appoints the cabinet, but the big advantage is you have 6 years, and because there's no presidential re-election, you're not distracted with the idea of the short-term goal of getting re-elected. So you can actually use the 6 years to do something meaningful. And I was lucky to serve the entire 6 years, even though there were a couple of times when I thought that might not happen if I was gently asked to leave because of some controversies that we can get into. The main set of events that happened there that I'll tell you a little bit was a large-scale reform to introduce universal coverage through both a new insurance mechanism and a whole new set of policy-making processes. The insurance mechanism happened because, like many other countries, including this one, about half of the population, in our case 50 million people, were uninsured. And just like in the United States, that was because access to insurance was linked to formal employment, was a benefit of employment. And the big change was to turn that, instead of being a benefit of employment, meant to make it a universal right, a right that people enjoy just by the fact of living or residing in the country. And that was the switch. Now, it was a major transformation. I think now with distance, and we can say that it is probably one of the deepest transformations that have happened in that particular health system. It's also been an experience that has been, by design, highly evaluated and documented. So it's also had, I think, a wider influence in other experiences in other parts of the world. So what I like to do is tell you a little bit about how that process came and how the decisions were made. I have found it very helpful when I talk about this reform to think in terms of what a professor here at the School of Public Health, Michael Reich, has called 3 pillars of public policy. A technical pillar, a political pillar in the good sense of the word political, meaning the ability of reaching agreement on socially valued goals rather than politicking, and then the ethical pillar. So technical pillar, political pillar, and ethical pillar. The technical pillar is mostly about building a case with good evidence. And for those of you here and the audience that's going to watch this in the webcast, who are in a university, this is a very nice example of the way in which good analysis can actually change, not just policy, but change actually public awareness. A big part of what we do in academic institutions and research organizations is not just to answer questions that policymakers may already have formulated, and then they come and ask us, researchers, how do I deal with something. Very often our main role is to frame the question. And this was exactly what happened in Mexico. There was the preconception, the assumption that no one had tested, that we had a publicly funded system. People thought we had a publicly funded system because there were a lot of public entities. We had a Ministry of Health, social insurance. And when we actually got to the point of measuring financial flows through a tool called national health accounts, when we came to calculating the national health accounts, to everyone's surprise, it turned out that more than half of all expenditures in health were private out-of-pocket expenditures, 52%. This was a shock. Furthermore, that analysis revealed that there were about 4 million families every year that became ruined, impoverished, because they had to face the prospect of paying for care. And that most of those were uninsured families. We brought to light that half of the population was uninsured, and that these people were facing the consequences of catastrophic expenditures. Now, if you think about it, it's not rare that this was not in the public awareness, because even though in the course of a lifetime, we will all, at some point have a serious illness or accident, because we are all going to die one day, at any given point in time, except when there's a large epidemic, it's only a small minority of the population that are suffering very serious illness that can push them into poverty, or if they're already poor, can really sink them into poverty. So it's easy to fall in what Amartya Sen, another professor here and Nobel laureate, has called the invisibility issue. It is not visible, and the term evidence, the etymology of evidence, is to make visible. So what we do with good evidence is to bring social realities that would otherwise be hidden from public awareness and public debate and policy formulation, bring them into the visible sphere of a society. And that was exactly what happened there. Something that no one thought was the case, and an issue that was, as I said, forget the policy debate, it was not in the public awareness domain, became visible. And that helped us build a very strong case. Then further analysis showed that part of the reason was that we had had this huge change in the dominant patterns of disease, more chronic, expensive diseases, but we had a totally underfinanced system. No one had actually quantified those variables in a rigorous manner. And we were able to make the case that there was a substantial need for further investments in health. Now, that, and I'm summarizing a fairly complex set of issues, that evidence became extremely powerful in dealing not just with now I'm moving to the political pillar, not just with other parties, but actually with what turned out to be the toughest group to convince, and that was the Ministry of Finance. Because it was clear that to solve this problem, we needed to correct the chronic underfinancing. Mexico was spending, at that point, less than 6% of its GDP on health. And it was clear that not only was that very little money, but it was very little value for money. It was not very well spent. But the bottom line is we needed to increase expenditures. And to get the Ministry of Finance to agree on that was a necessary step even before we could get to the President and to the Congress. So one of the lessons I learned is that you got to learn to speak their language. That pure moral persuasion, which we're very prone to acquire in academia, is not enough. So I tried to think as the Minister of Finance, who's facing 1,000 claims on a limited budget, and see how we could argue for this. So probably the best decision I made was to create a staff unit called the Economic Analysis Unit. I use the word economic. Hire a card-carrying economist, a PhD from Chicago, the same place where the Minister of Finance had gotten his doctorate, and simply create a space of dialogue where our voice would be respected. Because my observation was that ministers of finance tend to look down on health people who are always there to ask for more money, and there's no way of I mean, you can just continue to spend and spend and spend on health, and there's no value coming out. This is a very common attitude. So to become respectable interlocutors of a key hurdle that we had to surmount was a fundamental part of the political strategy. Now, I talk of pillars because they need to work in harmony, like in any construction. The three pillars need to work in harmony. So again, how do you create that space of dialogue to surmount a political obstacle is you build very good evidence. And getting an economic analysis unit, every time we went to talk with the people at the Ministry of Finance, we weren't about telling anecdotes of poor people becoming impoverished or the sort of thing that advocates tend to do. We always came with numbers. And we actually demonstrated something very important, again, using good evidence, that fixing the health system was not just the right thing to do, but it would also help the economy. It would make the economy more competitive, and it would improve productivity, would improve the social return on the investment in human capital through education, because healthier children learn better, well-nourished children learn better, healthy adults are more productive. You create a better investment climate. If you have the right kind of insurance, companies become more competitive rather than less competitive. So always coming with good evidence and good numbers was a key part. And then we did, however, bring the ethical deliberation to this equation. And that was mostly to try to force a discussion on whether we were going to translate the abstract notion of health as a social right into a set of specific entitlements. And that was a key part of the design. And again, it comes back to feeding the political pillar, because one of the things that was appealing to the Ministry of Finance is that we offered a new way of thinking about using the public budget. Instead of the standard supply-side subsidies, where you basically subsidize inputs, we said, look, the main thing we're going to do here is be explicit about a set of entitlements. And we're going to use those entitlements. We actually did this. We used the entitlements, the set of benefits that would be covered, which was fairly comprehensive, to then, along with the estimate of frequency of utilization, derive what were going to be the resource requirements. And then when we came to the Ministry of Finance to say, we are short 1 full percentage point of GDP, that's the shortfall. We had a very rigorous logic of how we had dealt with that. So the number was eminently credible. Now 1 percentage point of GDP sounds like very little, it's a lot of money. It is a lot of money. Think what a 1 percentage point of GDP in the United States would be. But Mexico at that point had a GDP of about $800 billion. So that was a substantial amount of money. But it was not an arbitrary number. A lot of advocates used to say, let's spend 5% of the GDP on health or whatever, an arbitrary number, and that's a non-starter. It was the rigorous way. The interesting thing, though, is that the whole notion of entitlements was ethically defensible and was at the root of the whole of the ethical pillar. To say, it's not enough, like Mexico had done, to declare in the Constitution that there's a right to health care. You need to translate it into actionable entitlements. Otherwise, it's meaningless. And there, the discussion was also very timely, because what happened in the year 2000, and actually the whole reason I ended up in the cabinet, is that Mexico had a landmark election. Mexico had been for 72 years ruled by one party. It was not a dictatorship. But it was a fairly authoritarian regime. And over 20 years, since the student movement of the 1960s, the late 1968, a gradual process of democratization had been taking place. But the big turning point was the election of 2000. It was the first fully democratic election, and a president from a different party got elected than the one that had ruled for 72 years. So it was pretty momentous. And the whole idea was democracy. So to build the ethical pillar, I said, democracy doesn't end with exercising civil and political rights, like the right to vote. It includes also social rights. And what we have now is a situation where there is this social right to health care, but some people exercise it differently than others depending on their position in the labor market. If you have a job, you have insurance. If you don't have a job, you have to go and ask for that, and maybe the public sector will subsidize you or pay out of your pocket. Imagine if we did the same thing for the political right that we fought so hard now to gain, which is the right to vote. Imagine if people voted differently depending on whether they had a job or not. Or, by the way, this is not hypothetical. That's how the right to vote started, right? Only landed people could take it, only people above a certain income, only men. Even in this country, it was not until the 1950s when women could actually vote. So in the political rights, we gradually built a universal right to vote. And my point was, the exact same standard should apply to social rights. The way you exercise that right should not be a function of your gender, your income, or your labor market status. So that's another lesson. Link the reform to the larger societal interest. In that moment, the big question in Mexico was democracy. So instead of health being something out here, it was very much built into the whole idea of building a fully democratic society. And creating those links was immensely valuable to overcome the opposition of the half of the people who already had insurance and who were afraid that this was somehow going to dilute it. You said, well, you can't vote differently depending on your labor market status. You shouldn't have access to insurance depending on that. It's as much a right as the other. So that linkage proved to be very, very crucial. The last point I'll make on the ethical pillar was, again, to show how this interact was the ability to demonstrate to the decision makers how the allocation practices that they followed actually revealed a value set that was opposite to their stated values. The specific example, I have the image right in front of me, was sitting in front of the Appropriations Committee of the Congress with the evidence, that's the technical pillar, talking to the member of Congress, who happened to be a man, and telling him, so Mr. Congressman, you actually believe that the life of people depends on whether they have a job or not, right? Say, no, I believe that all human lives are valued the same. Well, your allocation decisions reflect something differently, because guess what? It turns out you're allocating twice as much money per person from public subsidies to the uninsured and to the non-uninsured. So it means you value the health and therefore the life of those who have insurance twice as much as those who don't. And since the only difference is that some have a job and others don't have a salary job, you value life according to people's jobs. I said, no, that's not true. I value lives equally. Well, then why don't you make your allocation decisions reflect your stated value set? You have to increase the allocation and make sure that everyone has the exact same amount of subsidy. And that was at the core of the budget increases. So it was not just asking for more money. It was actually confronting in this case, the members of Congress with their own allocation decisions. Anyway, those are some examples of how the three pillars interacted with each other and how good evidence built a political case, how the ethical dimension also strengthened the political agreement. In the end, in April of 2003, a new law was passed with a huge majority from actually votes from all the parties represented in the Congress. It turned out to be that because it was a new democracy, there were few other areas of agreement. So I always said that the democratization of health had been very good for the health of democracy, because it actually showed a concrete arena where we could actually agree. And then Mexico is a federal republic like the US with 32 states. Then you had to get the buy-in from all the states. It took a year and a half, but after 18 months, every single state in the country had signed up to the new insurance scheme. Again, an unprecedented level of consensus. So using the political pillar also again to show that democracy actually could work was a key part. And obviously the states were fundamental to the implementation, because in a federal system, you had, those were going to be the implementers of the reform. I just heard my successor, the current Minister of Health, report. We built a reporting requirement. That was another big part of the reform, and a requirement in law to evaluate the reform. By the way, I think in the U.S., a lot of the anxiety that the reform produced would have been at least mitigated if there had been an explicit commitment to do periodic evaluations with regular reporting to Congress. So we did that, A, because I do believe in evaluation, and B, because it also served to build the political support, because with twice a year detailed reports to Congress, that was a way of assuring that if something was wrong, we could correct the course. So we built a major evaluative component. So we more or less have a good idea of what's happened. In the last report to the Congress that's coming due in December, the Minister of Health will report now that out of the initial goal of 50 million, by this December, there are already 42 million people enrolled in the new insurance scheme. So Mexico is right on track to meet the goal that was expressed over a 7-year period. The law came into effect January 1st of 2004. So by 2011, we will have universal coverage. And the budget tripled in this period of time. This extra percentage point meant a tripling of the budget. It's completely changed the face of the health system in Mexico. So those are a few of the insights I gained linked to the larger concerns of society. I'd anticipate who is the opposition, and don't think of them as your enemies. Use the power of empathy. Put yourself in their shoes, and try to understand why they would be opposed, and then articulate a case that will address their concerns, not yours. And then make the value set that's expressed in behavior explicit and confront people with the incongruence between what you say and what you do. All of those were very crucial to achieving the political consensus that this particular measure achieved.
All right, we're going to take questions, but I want you to think a second. Years from now, when you're thinking about a major decision that you, in your own role, are going to implement, and you say, what should I have asked them? This is the time to think about what it is, when you're in his position, you wish you followed up on. So this is a unique opportunity, and the series is all aimed about lessons learned about getting things done that really count. Tell us who you are when you ask a question, and make it brief, and then we'll move it around as quickly as we can. We can be heard without microphones, right? So that is a unique situation. It took me 6 minutes for them to take the microphone out of my hand, that you actually can be heard. So first question. These events cannot have shyness.
Well, thank you. That was a really exciting story, and I have a lot of questions I'd like to ask about the U.S. healthcare system there. But in terms of the decision...
One less, just quickly you.
Oh, and my name's Dan Henderson. I'm in the one-year MPH program. There's been a lot of fracas, we'll say, about how much to ask for in the U.S. healthcare reform push. So there was the single-payer camp, the individual mandate camp, the employer mandate camp, etc. You set your sights on 1% of GDP. How did you calibrate what would be the right ask to get what you needed, but not, but balance the risk of winning it all?
Well, I think, having a clear explanation of what is it that you're asking, so that it doesn't sound arbitrary, was a huge improvement. When we were putting together the case for this reform, a group of members of Congress, also knowing, mostly through the numbers we had put out, that we had an underfunded system, had come up with the idea that we needed to have 5% of GDP for public expenditures. So remember, Mexico was spending about 5.8, but more than half of that was private out of pocket. So it meant that public expenditures were around 2.5%. So he said, no, we got to go to 5%, and this is going to happen in this administration, and we're going to write this into law. So, we just, I remember going with the Minister of Finance and showing him a graph with 3 lines. One was just the inertial growth of health spending, which was mostly driven by out-of-pocket, because the fact of the matter is, we had an aging population, more chronic diseases. It was just going up. We did nothing. Then this proposal that was already in the floor of the Congress to double public expenditure with this arbitrary number. Well, that of course went off the roof. And there are proposals of the 1 percentage point over a 7-year period, which we knew that was fiscally possible. And it turned out that with respect to the baseline scenario, it was practically identical. It was a growth in expenditures, but it didn't involve more money, contrary to if you just ask for 1 percentage point, you would say, wow, that's a lot of money. Well, no, it's actually what you're going to spend. But guess what? Instead of having out of pocket that's leading people to liquidate their savings, which has a very bad macroeconomic effect, making people poor, which is also very bad for the economy, this is the same money but much better spent, because you're actually creating a risk pool. You're dealing with the fundamental issue in health, which is uncertainty. And we have insurance to deal with uncertainty instead of having people pay out of pocket. So it's the same money but better spent. But, if you don't do this, and you just fall into inaction, which is the standard response from ministries of finance, the other camp is going to pass a law that is going to force you to this much steeper and higher level of expenditure. That graph actually sealed the deal to go forward. So we had 2 things. We did not overestimate to play the game. We actually had very solid numbers. It was 1 percentage point. And the logic was impeccable. We were not asking for inputs. We were not saying we need to hire more doctors, build more clinics. We started with the end in mind. These are the benefits. We costed them. We estimated the frequency of utilization, and then we said, this is the volume of resources you need to provide these services, which is your social contract to deal with, to provide these benefits. And the numbers were so good that they were there. The usual negotiation tactic of going above so that then you really reach your target, that was done by the other group. They were that was so much of a higher ask that it made ours look very reasonable. But also we were able to articulate it in a way that was incredibly persuasive, and the numbers were good. So that was the tactical move that happened, that we used. And again, it's using good evidence to build the political pillar.
My name is Susana Ramirez, and my question is, can you talk about one of the mistakes that you made and how did you recover from it?
Well, I'll tell you mistakes and then unexpected things that happened. I think there was one mistake that was pretty bad, and it was that the team I had assembled to deal with the Congress were technocrats, like most of my team and like me. And I pretty much realized that they are not effective in engaging in the dialogue, in the political dialogue, that we needed politicians there. Because I was a non-partisan appointment in the cabinet, I had a lot of trust from all the parties, because everyone knew that I was a technocrat, that I didn't have a political agenda underneath, and that I was not a member of any party, including the president's party. So they all felt confident in talking to me. I also had studiously analyzed the platforms of the three dominant parties, and I met with the leadership of the three and gave them the spiel in a way that resonated and took words from their own political platforms. And then I told them what I had done with the other two parties. I said, this is the one point where you can actually see a lot of convergence. Now, Mexico is fortunate because, I have to say this doesn't apply everywhere. There are three dominant parties, and they're all clustered around the center. So there's a center-center, there's a center-right, and then a center-left. But we don't have extremist parties. So it would have probably been different if one of the parties was. There are extremist factions between the center of right and the center of left, and they can polarize the debate very easily, and that has happened. But the mainstream of the parties are more or less clustered compared to other countries. Having said all of that, you still needed a politician to talk to politicians. So I didn't apply the same analogy of talking with the Minister of Finance, of having a card-carrying economist, to the beginning of the political dialogue. And then it almost failed there. So the way I recovered was I quickly, completely changed that part of the ministry and built what I call the commando, the political commando. And this was a group that had no other job but to push this through Congress. We even, I know I'm on the record, but time cures everything. We even violated a few rules of parliamentary procedure by being on the floor where we were not supposed to be at the time of the vote. But that could have been a very costly mistake too. So the rule here is you got to have a team that's as diverse as the people you need to engage. If you have only people like you, it doesn't work, because even all of you are very talented. You cannot be everything for everyone. You got to have a team that reflects the richness of the various constituencies you're going to deal with. So that I think almost put the whole thing at risk. But then there were some unexpected issues. We just had approved this, and a huge controversy came up because there was a parallel process going for 3 years about the approval of emergency contraception in Mexico. And the timing there actually in the end worked out well. But if it had come before, it would have contaminated, and we might have lost the support of the right of center party, which happened to be the president's party, so that would have been pretty bad. So it was possible to push that decision a little bit, so it came after the insurance law was approved. Here in the audience is Dr. Anna Langer, who was very close to that process because at that point she was the representative of the Population Council in Mexico. But that was a very polarizing debate, as you can imagine, in a country where a majority of people are Catholic. The church was explicitly opposed, and but again, this was another case where good evidence carried the day. The main issue here was whether the morning after pill produced abortions. We were able to show that far from that, it was probably the single most important intervention we had to prevent unwanted pregnancies and therefore abortions. In addition to the right of women who have been subject to sexual violence of actually doing something about it. But the pill itself was presented convincingly as a measure to prevent unwanted abortions. Yet, while we did that, the polarization was very explicit because I was being attacked by a very powerful groups in society. In the end, I think the timing was very fortunate because the law had been approved, and as it turned out, I offered the president to resign because we had made a deal at the beginning. And that's another lesson. I mean, set your conditions explicit at the beginning. So I had actually had this conversation when I was invited to join the cabinet, and I told the president. The president loved the idea of the insurance program. And I remember, I didn't know it was actually going to happen, but I actually remember saying, but there are other issues that will come up, and particularly some have all these ethical and moral dimensions, like reproductive health issues. My position is we have to formulate policy on the basis of evidence, not on the particular ideological preferences of any group in society, any group. And the president, do you agree with that? And he said, he looked at me like, of course, that's why I'm inviting you to, to be the health minister. But when the test came, when we actually had the controversy, he behaved with great integrity, because he actually, when I said, I didn't come here to create you problems, there were the more conservative members of his party were asking for my resignation. I'm not going to back up on this decision, because the decision was made after 3 years of deliberation. Everyone participated. The evidence is very clear. But here's my resignation if you need it. He said, no, don't resign. Just explain to everyone what you're telling me. And then the next day, the Office of the President actually endorsed the policy that the Ministry of Health had proposed, which was a big triumph. As it turns out, this was probably the most popular thing the government did, because people don't want anybody, whether it's the government or the church or whoever, to tell them how to run their private lives. And every poll showed that even very religious people were overwhelmingly in favor. I mean, the popularity of the approval of emergency contraception was at some point, one poll I saw was like 70% of people supported that. So that would have been a mistake if that conversation had come 2 months before. It would have interfered. No, a little bit more, about 6 months before. It would have interfered with the approval, and we would have lost the focus that we had. So this is a lesson here. I mean, at how many points during the healthcare debate were all these distractions coming and creating debates in other things that were not the focus. So that could have been a fatal mistake. But fortunately, the timing worked out well, and it didn't distract, and we got the law approved, and then we also got the emergency contraception, and as I say, the two actually synergized very well, because that gave a lot of popularity to the Ministry of Health, which helped with the implementation of the health insurance, interestingly. But if the timing had been wrong, it would have derailed the health insurance debate.
Peregrin Dalzell, MPH student here. Just wondering, you've talked about coming up with all the numbers and proceeding forward in a very calculated and rigorous manner. Was there any leadership that you looked to, or any other countries that had instituted similar policies that you took good examples from and acted out on?
Oh yeah, very much so, and this was very much part also of the public deliberation. I mean, I had the advantage that I actually studied health systems, so I knew a lot about other experiences, both good, but also more importantly, negative lessons were very important. There was a particular country that had designed the most elegant health insurance. In fact, we took a lot of ideas from that, but the immunization rates went down. And I saw that many countries that pass health insurance, because that's such a dominant feature, actually will neglect public health programs. And no matter how well you insure people, if your immunization coverage goes down, that's not a good reform. So one of the things we did, based on that lesson, and I used that negative lesson to argue for, was that the bill that created the insurance mechanism also created a separate fund for community, what we call community health services. And that includes everything where there's no spontaneous demand. So it's obviously all the non-personal services, the sort of public goods side of the health system, all the epidemiologic surveillance, for example, which is a pure public good, because it has all the characteristics of what economists call a public good. So included that, but it also includes some personal health services where there's no spontaneous demand, and that is most of the early detection and preventive services fall in that category, where you actually need campaigns to actually get people to get immunized or get the children immunized or do mammographies or do blood pressure checks, whatever. And that went into a separate fund. Was the first time that there was a protected fund. One of the most enlightened parts of the American healthcare reform is it actually has exactly that same idea. It has as one of the titles in the Act is about health promotion and disease prevention, and that's very good. That's a very enlightened situation. But that came in our case from a negative example, and we also use positive examples. One thing that helped a lot was that just before joining the Mexican government, I had been working at the World Health Organization, and one thing we did there was to produce the World Health Report 2000 that did the rankings of health systems performance. Now, I was responsible for the report, but mostly for the conceptual part. I did not do all the measurement part, which was a heroic exercise because of the weakness of some of the data. But the interesting thing was that Mexico didn't do very well because of the high level of out-of-pocket, because this index of performance penalized countries where there was high out-of-pocket. So Mexico, because of that, did very poorly. In fact, on the overall index, we were like number 50 out of the 192 countries, 191 back then. And in the sub-index of financial fairness, which measured out-of-pocket, we were like 120. And I used those numbers of comparative, international comparison to make the case that we were really doing a very poor job compared to other countries. Interestingly, the number for the US, which was 37, was still alive in the health reform debate of last year. 10 years later, they were still quoting that number. And again, with the same idea that, how can we be number 37? So international comparisons are very good, both to get ideas, in a legitimate, intellectually honest way. I like to say not so much to adopt as to adapt ideas, but it's also very good to show your own shortcomings and use that in a sort of political judo, use the force of your opponent to actually go against conservative elements that don't want reform by showing how poorly you're doing compared to the rest. And then also designing parts of your reform with reference to other places that failed to do that and then had a major issue like the example of the immunization coverage. So yeah, that was very prominent in the discussion.
Manpreet Singh, I'm also MPH Global Health. Dean Frenk, you mentioned a lot of examples of using data to drive the process. I'm just wondering if there are any examples where the data was unexpected or didn't support something that you would have liked to have implemented, and how did you change your plans to reflect that unexpected data?
That's a very good question. There were, it was a balanced mix of good data and then ethical deliberation as well. Let me give you an example. The way the law is structured, the set of entitlements are divided into two packages. One is a package of what we call essential personal health services, and that's basically what's covered at primary and secondary level. But it makes them explicit because otherwise you cannot do the costing I was explaining before. And then we created a separate fund for protection against catastrophic expenditures, and those were the really expensive things. And the law said there was not enough money because that was built as a reserve fund with 8% of the total money generated by the insurance scheme, okay? And that was actually calculated, why it was 8%. So, because you had 7 years to enroll people, and actually the law mandated that we start with the poorest, and the premium is means tested, so the people you were enrolling at the beginning were in the exempt category. The poorest 20% are exempt from paying any premium. All the early collection, you had very little collection on that, and then the federal and state subsidy is a function of your enrollment. So it grows as you enroll more people. But in the early years, you had a problem of how to fund that catastrophic. So the law says that it will cover a growing number of interventions, but the priorities will be set using cost, effectiveness, and social acceptability. And the reason we introduced the third one was the real observation that some very cost-effective measures may be socially unacceptable. Lock up everyone who has AIDS so that they cannot. And this is not a hypothetical. At the beginning of the AIDS epidemic, this actually happened. Or sterilize people who have carriers of a genetic disorder, and it's very cost-effective. It's not socially acceptable on ethical grounds. But it also gave us a little bit of room to include some things where maybe the numbers were not going to show that this was the next priority. And there were important reasons to include it. And to make this transparent and not subject to any kind of undue political or economic influence, this was done by a deliberative body, which is called the General Health Council, where you have everybody, every constituency sits there, the various parts of government, the professional bodies, the NGOs that represent various diseases. So you had to fight it out there. So there was a deliberative component there that allowed for some issues. And then, very, very interesting things came up. So the law said cost effectiveness, but it also said burden of disease. So, the hemophiliacs came, and they said, why are we not included? Well, very few people suffer hemophilia. And they went through this whole rationale where they said, wait a minute, the intervention is as cost effective as antiretroviral treatment. There's many more people with AIDS. But why is that relevant? Intervention is cost effective and it's socially acceptable. Why is burden of disease relevant? So that, for example, was a very interesting revelation. In the end, the treatment of hemophilia was covered along with AIDS. AIDS was the first thing, and then that got covered, universal treatment. So it made for a lot of interesting issues that we discovered. The other thing that I would say, maybe falls into the category of mistakes. When we created the community fund, the Fund for Community Health Services, we didn't attach a fixed percentage of the total that would go there. And at the beginning, we struggled with that because, again, the political impulse is not to fund the public goods and the preventive stuff. In the end, it actually worked itself out. But if I had to do it again, I was a little bit surprised by the initial numbers that we weren't filling that fund as quickly as I had thought. So in the end, it required other measures to actually also bring more money to the preventive fund or the Fund for Community Services. So those are some examples of how, as implementation went along, we were adjusting some of the design elements. The last one, which I did not correct, but the new government did, was that the initial enrollment was per family, and the subsidy that followed the enrollment was per family. So we started getting all these weird families. We had made all the actual calculations on the basis of 4.2 members, which was what the census told us, and we were getting all these families with 2 and 3 members. because obviously the states, which were receiving this money, had an incentive to declare as separate families different units that were really the same household. And so now it's been changed, and the allocation is per individual, not per family. So, there's a lot of things that you need to. The important thing is we had all the information systems to detect these things. And then the family one was tricky because it required a change in the law. But, my successors actually did that, and now it's per individual, and you avoid this perverse incentive to fragment family units when you allocate money.
My name's Alifia Shimura, and I'm a 2-year master's in health policy and management. My question is around, you talk about a transformative change. My question is, how do you sort of balance the pace of the change that you achieve both the catalytic effect that you're intending for and also ensure sustainability? So sort of how do you balance both of those?
That's a great question. But look, the neat thing of politics is that you never know if you'll have the job the next day. It's the ultimate in job insecurity. So you always live with the pressure that if you don't get it done, you may not get it ever done. This political commando, I told them, we gotta get this approved in this session of Congress. Because we have midterm elections, and I didn't know what the next Congress was going to look like. And they told me it cannot be done. It can't be done because we haven't built the coalition, etc. I said, well, we got to do it. The law was approved by the floor 15 minutes before the end of the session, literally. But we made it. And it was it was good. If we hadn't done it, if we had just said, well, we'll do it in the next session, it's 3 months later, the Congress will come in again. I don't know if that would have happened. So, the pace is a lot dictated. Now, if you write a good law, it will be sustainable. So there shouldn't be an issue. The big item for sustainability is evaluation. Because when the change of government, the scheduled change of government happened, there was so much evidence with good external evaluation. Part of it was done here at Harvard. Gary King did a randomized, very elegant design. The results were so good that the new administration had no second thoughts about discontinuing the program or anything. And they've actually continued it with great enthusiasm. The evaluation was fundamental to ensure continuity across administrations.
We have 2 more questions.
Jennifer Yeager, MPH Policy. One of the through lines in economic our classes here has been unintended consequences. And assuming that universal health coverage is successfully implemented and we have decrease in infant mortality rate and increase in life expectancy, would there be economic consequences that we would need to perhaps anticipate or address just in terms of having a potentially larger population that is going to live longer and have increased demands beyond the healthcare system?
Absolutely. One of the failures of public policy is not to anticipate the price of success, and you have to build the price of success. And when we fail to do that, then all of a sudden say, oh, but how did this happen? Well, because you were actually successful. I sold the reform a lot by saying we have been victims of our own success. We're getting all these children who used to die from acute infections are now living to the age where they are getting this much more complex disease. You got to build the price of success into any policy and be explicit about it. But it's much better to have that than the alternative. So.
Second law of being a decision maker, you end on time. So we want to thank Dean Frenk, then Minister Frenk, for really kicking this session off.
Thank you.
Briefly, in the decision-making series, we will be having Charlie Gibson, for those not from the United States. He is the leading network anchor for ABC News, and he's going to talk about what makes the world news and not. And then we're going to have David Gergen, who has been the advisor to more presidents than anyone living, who's going to talk about U.S. decision-making in these very same issues and what presidents could have done. We'll be notifying you about this, but they all have the same focus, lessons learned, so when it's your turn, you can move this decision-making along more incredibly. Thank the Dean again, and thanks for what he did in Mexico, which is incredibly important. And we'll see everybody next round. And Betty, thank you very, very much, and thank the group for really doing this.